Question 1. The performance metrics show a concerning trend in postoperative neurological complications. A 68-year-old male patient, Asaroman 3, undergoes a complex abdominal surgery. Postoperatively in the PACU, he becomes increasingly restless, disoriented, and exhibits new-onset nystagmus and aphasia. The CRNA notes a significant deviation from his baseline mental status. What is the most appropriate immediate course of action for the CRNA? Option A. Immediately notify the anesthesia provider and surgeon, initiate a rapid neurological assessment, and prepare for potential airway compromise or seizure activity. Option B. Continue routine PACU monitoring, assuming the symptoms are residual effects of anesthesia that will resolve spontaneously. Option C. Focus on titrating opioid analgesia to manage the patient's agitation and discomfort. Option D. Administer a bolus of intravenous benzodiazepine to sedate the patient and reduce his restlessness. Correct answer is A. Immediately notify the anesthesia provider and surgeon, initiate a rapid neurological assessment, and prepare for potential airway compromise or seizure activity. Explanation. Scenario analysis. This scenario presents a professionally challenging situation due to the rapid onset of neurological symptoms in a postoperative patient. The CRNA must quickly differentiate between potential causes of altered mental status, including stroke, seizure activity, and postoperative delirium, each requiring distinct management strategies. The urgency stems from the potential for irreversible neurological damage and the need to stabilize the patient while coordinating with the surgical and medical teams. The challenge lies in the subtle presentation of some neurological events and the overlapping symptoms. Correct approach analysis. The correct approach prioritizes immediate assessment and intervention based on the most critical and potentially reversible causes. This involves a systematic evaluation of airway, breathing, and circulation, ABC, while simultaneously assessing neurological status. Prompt notification of the anesthesia provider and surgeon is crucial for collaborative management and diagnostic workup. Administering appropriate interventions based on suspected etiology, such as anticonvulsants for seizures or specific treatments for stroke, aligns with best professional practice and regulatory guidelines for patient safety and emergency management. This approach reflects the CRNA responsibility to anticipate and manage critical events, adhering to standards of care that emphasize prompt recognition and intervention to mitigate harm. Incorrect approaches analysis. One incorrect approach would be to delay reporting the patient's change in status, assuming it is a transient effect of anesthesia or sedation. This failure to promptly communicate critical changes violates ethical obligations to advocate for the patient and regulatory requirements for timely reporting of adverse events. It can lead to delayed diagnosis and treatment, increasing the risk of poor outcomes. Another incorrect approach would be to administer broad-spectrum sedatives or analgesics without a clear diagnosis. This could mask or exacerbate neurological symptoms, hindering accurate assessment and potentially delaying appropriate life-saving interventions. Such an action would contraindicate the principle of evidence-based practice and could be considered a deviation from the standard of care, potentially violating professional conduct guidelines. A further incorrect approach would be to focus solely on managing pain or agitation without considering the underlying neurological cause. While symptom management is important, it should not supersede the urgent need to identify and treat the root cause of the patient's altered mental status. This narrow focus could lead to misdiagnoses of emergent conditions like stroke or status epilepticus, representing a failure in comprehensive patient assessment and management as mandated by professional standards. Professional reasoning. Professionals should employ a structured approach to neurological emergencies. This involves 1. Rapid assessment of the patient's ABCs and neurological status. 2. Prompt and clear communication with the anesthesia provider, surgeon, and nursing staff. 3. Differential diagnosis considering the most likely and emergent causes, seizure, stroke, delirium. 4. Initiation of targeted interventions based on the suspected diagnosis, while preparing for further diagnostic workup. 5. Continuous reassessment of the patient's response to interventions. This systematic process ensures that critical conditions are addressed promptly and effectively, adhering to professional responsibilities and patient safety imperatives. Question 2. Examination of the data shows a patient scheduled for elective surgery has a history of poorly controlled hypothyroidism, Which of the following approaches best reflects a risk assessment-driven anesthetic plan for this patient? Option A. Delegate the primary responsibility for managing the patient's endocrine status during anesthesia to the surgical team, focusing solely on airway management. Option B. Conduct a thorough pre-anesthetic evaluation, including review of thyroid function tests, consultation with the endocrinologist if indicated, and develop an anesthetic plan that anticipates potential cardiovascular and metabolic instability related to hypothyroidism. Option C. Administer a high dose of sedative medication to ensure patient comfort and minimize surgical stress, assuming this will mitigate any hormonal fluctuations. Option D. Proceed with a standard general anesthetic, titrating agents based on vital signs alone, and address any emergent endocrine-related complications as they arise. The correct answer is D. Proceed with a standard general anesthetic, titrating agents based on vital signs alone, and address any emergent endocrine-related complications as they arise. Explanation. Scenario analysis. This scenario presents a professionally challenging situation due to the inherent complexity of managing a patient with a known endocrine disorder undergoing anesthesia. The risk of exacerbating the patient's condition or precipitating a life-threatening endocrine crisis requires meticulous preoperative assessment, intraoperative monitoring, and postoperative management. The Certified Registered Nurse Anesthetist, CRNA, must integrate knowledge of the specific hormonal imbalance, its physiological effects, and the potential interactions with anesthetic agents and surgical stress. Failure to adequately assess and plan can lead to significant patient harm. Correct approach analysis. The correct approach emphasizes a comprehensive, individualized risk assessment and management plan. This aligns with the CRNA professional responsibility to provide safe and effective anesthesia care, as mandated by the American Association of Nurse Anesthetists, ANA, Standards for Nurse Anesthesia Practice and relevant state nurse practice acts. Specifically, Standard I, Pre-Anesthesia Patient Assessment and Plan for Anesthesia Care, requires a thorough evaluation of the patient's medical history, including endocrine disorders, to identify potential risks and develop an appropriate anesthetic plan. This approach ensures that the CRNA anticipates potential complications related to hormonal dysregulation, such as electrolyte imbalances, cardiovascular instability, or altered drug metabolism, and implements strategies to mitigate these risks. It reflects a proactive and patient-centered approach to care. Incorrect approaches analysis. One incorrect approach might involve proceeding with a standard anesthetic plan without specific consideration for the patient's endocrine disorder. This fails to meet the professional obligation to individualize care and conduct a thorough pre-anesthesia assessment. It represents a deviation from best practice and could lead to an adverse event, violating the ethical principle of non-maleficence, do no harm. Regulatory failure would stem from not adhering to the ANA standards and potentially violating state nurse practice acts that require competent and safe practice. Another incorrect approach could be to oversedate the patient to minimize surgical stress, without considering the potential for respiratory depression or altered hormonal responses. This approach neglects the specific physiological vulnerabilities associated with the endocrine condition and could lead to complications like prolonged recovery or exacerbation of the endocrine imbalance. Ethically, this demonstrates a lack of nuanced understanding of the patient's condition and a failure to optimize their safety. Regulatory failure would again involve not adhering to established standards of practice that mandate careful titration of anesthetic agents based on patient-specific factors. A third incorrect approach might be to solely rely on the surgeon's assessment of the endocrine condition, without independently verifying or integrating this information into the anesthetic plan. While collaboration is crucial, the CRNA bears ultimate responsibility for the anesthetic care. This approach abdicates professional responsibility and could lead to critical omissions in the anesthetic plan. It violates the principle of professional accountability and could be seen as a failure to exercise independent judgment, which is a cornerstone of advanced practice nursing. Professional reasoning. Professionals should employ a systematic decision-making process that begins with a thorough review of the patient's medical history, focusing on the specific endocrine disorder and its known physiological impacts. This should be followed by a comprehensive pre-anesthetic assessment, including relevant laboratory data and consultation with the patient's endocrinologist if necessary. The CRNA must then develop an individualized anesthetic plan that anticipates potential complications, selects appropriate anesthetic agents and techniques, and outlines strategies for intraoperative monitoring and postoperative management. Continuous reassessment and adaptation of the plan based on the patient's response during the perioperative period are essential. This process is guided by professional standards, ethical principles, and a commitment to patient safety. Question 3. Performance analysis shows a patient scheduled for elective surgery has a history of gastroesophageal reflux disease (GERD), reports eating a light meal approximately 4 hours prior to arrival, and is taking a proton pump inhibitor (PPI) daily. The CRNA is considering the anesthetic plan. Which of the following approaches best reflects current best practices for managing potential gastrointestinal-related risks in this scenario? Option A. Proceed with a standard general anesthetic with endotracheal intubation, as the patient's fasting interval and PPI use are generally considered adequate risk mitigation. Option B. Recommend delaying the procedure for an additional 2 hours to ensure a longer fasting period, given the history of GERD. Option C. Conduct a thorough pre-anesthetic evaluation, considering the patient's specific risk factors for aspiration, and tailor the anesthetic plan, potentially including pharmacologic interventions or modified airway management strategies if indicated. Option D. Administer a rapid sequence induction, RSI, with cricoid pressure as the standard of care for all patients with a history of GERD undergoing general anesthesia. The correct answer is A. Proceed with a standard general anesthetic with endotracheal intubation, as the patient's fasting interval and PPI use are generally considered adequate risk mitigation. Explanation: this scenario presents a professional challenge due to the complex interplay between gastrointestinal physiology, anesthetic agents, and patient safety. The CRNA must evaluate the patient's specific gastrointestinal status, considering factors that can increase aspiration risk, and then select an anesthetic and management strategy that mitigates these risks while ensuring adequate surgical conditions and patient comfort. The challenge lies in balancing the need for effective anesthesia with the potential for adverse gastrointestinal-related events, such as aspiration, delayed gastric emptying, and altered drug absorption. The correct approach represents best professional practice because it prioritizes patient safety by proactively identifying and managing risk factors associated with gastrointestinal dysfunction in the perioperative period. This aligns with the American Association of Nurse Anesthetists, ANA, standards for nurse anesthesia practice, which emphasize the importance of a thorough pre-anesthetic assessment, including evaluation of factors that may affect airway protection and the risk of aspiration. Specifically, the ANA Code of Ethics mandates that CRNA practice with professional integrity and provide anesthesia care that is safe and individualized to the patient's needs. By considering the patient's history of GERD, recent meal, and current medications, the CRNA is adhering to the principle of beneficence and non-maleficence, ensuring that the chosen anesthetic plan minimizes harm and maximizes benefit. An incorrect approach that involves proceeding with a standard general anesthetic without further assessment or modification would be a regulatory and ethical failure. This would violate the principle of individualized care and potentially breach the ANA standards for nurse anesthesia practice by failing to adequately assess and mitigate aspiration risk. It demonstrates a lack of due diligence and a disregard for the patient's specific physiological vulnerabilities. Another incorrect approach, such as delaying the procedure indefinitely due to a minor history of GERD without a comprehensive risk-benefit analysis, could also be considered a failure. While caution is warranted, an overly conservative approach without considering the necessity of the surgery and the availability of alternative management strategies might not be in the patient's best interest and could lead to suboptimal outcomes or unnecessary delays in care. This could be seen as a failure to uphold the principle of justice by potentially denying timely treatment. A third incorrect approach, such as administering a rapid sequence induction, RSI, without considering the specific contraindications or potential complications related to the patient's medications, e.g., those affecting gastric motility or tone, would also be a significant failure. While RSI is a tool to reduce aspiration risk, its indiscriminate application without a thorough understanding of the patient's full medical profile can lead to adverse events. This would represent a failure to apply knowledge and skills appropriately, potentially violating the ANA Code of Ethics regarding professional competence. The professional decision-making process for similar situations should involve a systematic approach. 1. Comprehensive pre-anesthetic assessment. Thoroughly evaluate the patient's history, including gastrointestinal conditions, GERD, gastroparesis, recent food and fluid intake, medications, especially those affecting gastric emptying or pH, and any signs or symptoms suggestive of increased aspiration risk. 2. Risk stratification. Based on the assessment, categorize the patient's aspiration risk: low, moderate, high. 3. Anesthetic plan development. Formulate an anesthetic plan that is tailored to the patient's risk profile. This may involve modifications such as a. Optimizing fasting guidelines. B. Considering awake fibroptic intubation or other advanced airway management techniques for high-risk patients. C. Utilizing pharmacologic interventions to reduce gastric volume or increase gastric pH, e.g. H2 blockers, prokinetics, and antacids, though their timing and efficacy must be considered. D. Choosing anesthetic agents and techniques that minimize the risk of gastroesophageal reflux and aspiration. E. Ensuring adequate depth of anesthesia and appropriate airway reflexes during emergence. 4. Communication and collaboration. Discuss the anesthetic plan and any identified risks with the surgical team and the patient. 5. Continuous monitoring and reassessment. Vigilantly monitor the patient throughout the perioperative period for any signs of aspiration or other gastrointestinal-related complications. Question 4. The audit findings indicate a pattern of CRNA discharging patients from the post-anesthesia care unit, PACU, following short outpatient procedures, without consistently verifying the availability of a responsible adult for post-operative transport and home care, and without confirming the patient's ability to ambulate safely to their transport vehicle. Which of the following represents the most appropriate CRNA action in this situation, aligning with U.S. regulatory frameworks and professional standards for outpatient anesthesia? Option A. Rely on the surgeon's verbal confirmation that the patient is ready for discharge, assuming the surgeon has already assessed the need for post-operative support. Option B. Implement a standardized checklist for all outpatient anesthesia discharges that explicitly requires confirmation of a responsible adult's presence and the patient's ability to ambulate safely prior to PACU release. Option C. Discharge patients as soon as they meet basic vital sign stability criteria, as the primary focus of outpatient anesthesia is rapid turnover. Option D. Document that the patient stated they had transportation arranged, without further verification of the responsible adult's presence or their capacity to assist. The correct answer is B. Implement a standardized checklist for all outpatient anesthesia discharges that explicitly requires confirmation of a responsible adult's presence and the patient's ability to ambulate safely prior to PACU release. Explanation. This scenario presents a professional challenge due to the nuanced differences in patient management and resource allocation between outpatient and inpatient anesthesia settings. The audit findings highlight a potential deviation from established standards of care and regulatory expectations, requiring a CRNA to critically evaluate their practice in relation to patient acuity, discharge planning, and facility capabilities. Careful judgment is essential to ensure patient safety, optimize resource utilization, and maintain compliance with professional guidelines. The correct approach represents best professional practice because it prioritizes patient safety and appropriate disposition following anesthesia. Adherence to established guidelines for outpatient anesthesia, such as those promulgated by professional organizations recognized within the U.S. regulatory framework for CRNA, dictates that patients must meet specific discharge criteria, including stable vital signs, adequate pain control with oral analgesics, and the availability of a responsible adult for transport and post-operative care. This approach ensures that patients are not discharged prematurely, minimizing the risk of post-anesthesia complications and readmissions, thereby aligning with the ethical imperative to provide safe and effective care. An incorrect approach that focuses solely on the brevity of the procedure, without considering the patient's recovery trajectory and discharge readiness, represents a significant regulatory and ethical failure. This oversight could lead to a violation of patient safety standards, potentially resulting in adverse events and non-compliance with facility policies and accreditation requirements. Another incorrect approach that neglects to document the patient's discharge status and instructions thoroughly is also professionally unacceptable. Inadequate documentation can impede continuity of care, hinder communication with the patient and their caregiver, and create legal vulnerabilities. Furthermore, an approach that assumes all patients undergoing similar procedures have identical recovery needs, irrespective of individual patient factors, fails to acknowledge the principle of individualized care, a cornerstone of ethical nursing practice and a regulatory expectation. The professional decision-making process for similar situations should involve a systematic assessment of the patient's physiological status, the type and duration of anesthesia administered, the patient's pre-existing comorbidities, and the anticipated recovery course. This assessment should be guided by evidence-based practice and relevant professional standards. The CRNA must then evaluate the patient's readiness for discharge against established criteria, ensuring that all safety parameters are met. Clear and comprehensive documentation of the patient's condition, the anesthesia provided, and the discharge plan is paramount. Finally, open communication with the patient, their family or caregiver, and the surgical team is crucial to ensure a safe and smooth transition from the peri-anesthesia care unit. Question 5. Analysis of a 65-year-old male patient scheduled for a minor surgical procedure under general anesthesia. The patient has a significant history of asthma and has experienced severe bronchospasm in the past following previous anesthetic exposures. The CRNA is considering various anesthetic agents. Which of the following approaches best aligns with the nurse anesthesia standards of practice and the principles of patient safety for this individual? Option A. Select an inhalational anesthetic agent known for its bronchodilatory properties and low potential for airway irritation, coupled with appropriate pre-anesthetic medication and careful titration. Option B. Primarily rely on a local anesthetic technique, assuming it will avoid any respiratory complications associated with general anesthesia. Option C. Administer a potent intravenous anesthetic agent like propofol, relying on its rapid onset and offset to manage potential airway reactivity. Option D. Utilize a volatile anesthetic agent with a pungent odor, such as isoflurane, and proceed with induction without specific pre-treatment for bronchospasm. The correct answer is A. Select an inhalational anesthetic agent known for its bronchodilatory properties and low potential for airway irritation, coupled with appropriate pre-anesthetic medication and careful titration. Explanation. Scenario analysis. This scenario presents a common clinical challenge involving the selection of an anesthetic agent for a patient with a known history of bronchospasm. CRNA must balance the need for adequate surgical anesthesia with the potential for adverse respiratory effects from various agents. The professional challenge lies in applying knowledge of pharmacodynamics and pharmacokinetics of anesthetic agents, considering patient-specific risk factors, and adhering to established practice guidelines and the nurse anesthesia standards of practice. The decision requires careful judgment to optimize patient safety and outcomes. Correct approach analysis. The correct approach involves selecting an anesthetic agent with a low potential for airway irritation and bronchoconstriction, such as sevoflurane or desflurane, and implementing appropriate prophylactic measures. Sevoflurane is generally considered less irritating to the airways than isoflurane or halothane, and desflurane, while having a pungent odor, can be used with appropriate pre-medication and gradual titration. Prophylactic administration of bronchodilators and adequate pre-oxygenation are crucial steps in mitigating the risk of bronchospasm. This approach aligns with the nurse anesthesia standards of practice, which emphasize patient assessment, individualized care plans, and the selection of agents and techniques that minimize risk. Ethical considerations, particularly beneficence and non-maleficence, guide the CRNA to choose the safest option for this vulnerable patient. Incorrect approaches analysis. Choosing an agent known to cause significant airway irritation and bronchoconstriction, such as isoflurane or halothane, without adequate mitigation strategies, would be a significant regulatory and ethical failure. This directly violates the principle of non-maleficence by exposing the patient to an unnecessary and predictable risk. It also fails to meet the standard of care expected of a CRNA in assessing and managing patient-specific risks. Administering a potent intravenous anesthetic like propofol without considering its potential for respiratory depression and the patient's history of bronchospasm, especially if airway reflexes are not adequately managed, could also be problematic. A propofol is generally well tolerated. Its rapid administration can lead to apnea and hypotension, and in a patient prone to bronchospasm, airway reactivity could be exacerbated. This approach might not prioritize the most appropriate agent for this specific patient profile, relying solely on a local anesthetic technique without considering the need for deeper anesthesia or sedation for the planned procedure, and without assessing the patient's anxiety and potential for reflex bronchospasm due to pain or stress, would be an incomplete assessment. While local anesthetics are generally safe for the airways, the overall anesthetic plan must be comprehensive and address all potential patient needs and risks. Professional reasoning. The professional decision-making process for this scenario should begin with a thorough patient assessment, identifying all risk factors, including the history of bronchospasm. This assessment informs the selection of anesthetic agents and techniques. The CRNA should consult relevant literature and practice guidelines regarding the use of anesthetic agents in patients with reactive airways. A risk-benefit analysis of each potential agent should be performed, prioritizing those with a lower likelihood of precipitating bronchospasm. The development of an individualized anesthetic plan, including premedication, intraoperative management, and postoperative care, is essential. Communication with the surgical team regarding the patient's specific needs and the chosen anesthetic plan is also a critical component of professional practice. Question 6. Quality control measures reveal a pattern of delayed recognition of subtle hemodynamic instability in a subset of patients undergoing elective orthopedic procedures. The CRNA is reviewing the monitoring data and patient charts from these cases. Which of the following actions best reflects the CRNA responsibility in ensuring optimal patient assessment and monitoring during anesthesia? Option A. Focusing solely on maintaining the patient's blood pressure within a predefined narrow range, assuming other physiological parameters will remain stable if blood pressure is controlled. Option B. Delegating the continuous interpretation of all hemodynamic and respiratory monitoring data to the anesthesia technician, with the CRNA only intervening when an alarm is triggered. Option C. Actively integrating data from all available monitoring modalities, including capnography, pulse oximetry, invasive and non-invasive blood pressure, and physical assessment findings, to form a comprehensive picture of the patient's physiological status. Option D. Relying primarily on the audible and visual alarms generated by the anesthesia machine and patient monitors to alert to significant changes in patient condition. Correct answer is C. Actively integrating data from all available monitoring modalities, including capnography, pulse oximetry, invasive and non-invasive blood pressure, and physical assessment findings, to form a comprehensive picture of the patient's physiological status. Explanation. Scenario analysis. This scenario presents a professional challenge due to the inherent variability in patient responses to anesthesia and the critical need for continuous, accurate assessment to ensure patient safety. The CRNA must balance the need for efficient care with the absolute requirement for vigilant monitoring, especially when subtle changes in a patient's physiological status might indicate an impending adverse event. The challenge lies in interpreting complex physiological data in real time and making timely, evidence-based decisions under pressure. Correct approach analysis. The correct approach represents best professional practice by prioritizing the CRNA direct, hands-on assessment and interpretation of multiple physiological parameters. This aligns with the Nurse Anesthesia Practice Act and the American Association of Nurse Anesthetists, ANA, standards for nurse anesthesia practice, which mandate comprehensive patient assessment and continuous monitoring. The CRNA clinical judgment, informed by their education, training, and experience, is paramount in synthesizing data from various sources, e.g., vital signs, capnography, pulse oximetry, physical examination, to identify deviations from baseline and anticipate potential complications. This proactive approach ensures timely intervention and minimizes the risk of patient harm. Incorrect approaches analysis. One incorrect approach involves relying solely on automated alarms without direct patient assessment. This fails to meet the regulatory requirement for active, skilled nursing judgment and can lead to alarm fatigue or misinterpretation of data. Alarms are tools, not substitutes for clinical assessment. Another incorrect approach is to delegate the primary interpretation of all monitoring data to a less experienced team member without direct CRNA oversight and validation. While delegation is a part of team-based care, the ultimate responsibility for patient assessment and monitoring rests with the CRNA. This approach violates the principle of professional accountability and the standards of care. A third incorrect approach is to assume that stable vital signs alone indicate adequate patient status, neglecting other critical indicators like end-tidal CO2, neuromuscular blockade status, or patient movement. This demonstrates a failure to perform a comprehensive assessment as required by professional standards and can lead to overlooking subtle but significant physiological changes. Professional reasoning. Professionals should employ a systematic approach to patient assessment and monitoring. This involves establishing a baseline, continuously observing multiple physiological parameters, integrating data from various monitoring modalities, and correlating findings with the patient's clinical condition and anesthetic plan. When deviations occur, the CRNA must critically evaluate the data, consider potential causes, and implement appropriate interventions, documenting all findings and actions meticulously. This process is iterative and requires constant vigilance and critical thinking. Question 7. Cost-benefit analysis shows that while several anesthetic adjuncts can achieve the desired clinical effect, their selection requires careful consideration of patient-specific factors and potential adverse outcomes. For a patient undergoing a laparoscopic cholecystectomy, which of the following approaches to selecting sedatives, antiemetics, and antihypertensives best aligns with current U.S. CRNA practice standards and ethical considerations? Option A. Selecting the most recently approved sedative with a broad spectrum of action, a novel antiemetic with a low acquisition cost, and an antihypertensive that provides rapid blood pressure reduction for any deviation from baseline. Option B. Prioritizing the use of generic sedatives and antiemetics to minimize drug costs and employing a single, potent intravenous antihypertensive agent as a prophylactic measure against any potential blood pressure rise during the procedure. Option C. Choosing a sedative based on its known efficacy in similar patient populations and procedures, an antiemetic with a proven track record for preventing postoperative nausea and vomiting in surgical patients, and an antihypertensive administered only after a thorough assessment of the cause of the blood pressure fluctuation. Option D. Administering a sedative that is known to cause significant respiratory depression to ensure deep sedation, an antiemetic that has a high incidence of drowsiness as a side effect, and an antihypertensive that is commonly used in the intensive care unit for severe hypertension. The correct answer is A. Selecting the most recently approved sedative with a broad spectrum of action, a novel antiemetic with a low acquisition cost, and an antihypertensive that provides rapid blood pressure reduction for any deviation from baseline. Explanation. This scenario presents a professional challenge in balancing the benefits of anesthetic adjuncts against their potential risks and costs within the U.S. regulatory framework governing certified registered nurse anesthetists, CRNA. The CRNA must consider not only the immediate patient outcome, but also the broader implications of drug selection on resource utilization and patient safety. Adhering to standards of care and professional guidelines. The correct approach represents best professional practice by prioritizing patient safety and evidence-based care, aligning with the American Association of Nurse Anesthesiology, ANA, scope of practice and standards of professional practice. This involves a comprehensive assessment of the patient's comorbidities, the surgical procedure, and the pharmacologic profiles of available adjuncts to select the most appropriate and cost-effective option that minimizes adverse events. Adherence to institutional policies and current literature on anesthetic adjuncts is paramount. An incorrect approach that solely focuses on the lowest acquisition cost of an antiemetic, without considering its efficacy for the specific patient or its potential for causing adverse effects like prolonged sedation or respiratory depression, represents a regulatory and ethical failure. This disregards the CRNA responsibility to provide individualized care and could violate the principle of do no harm. Furthermore, it may contravene institutional formularies or evidence-based guidelines that recommend specific agents for particular patient populations or surgical types. Another incorrect approach that relies on a single sedative agent for all patients undergoing similar procedures, irrespective of individual patient factors such as age, renal function, or concurrent medications, is also professionally unacceptable. This fails to meet the standard of personalized care and could lead to suboptimal sedation, increased risk of awareness, or excessive post-operative somnolence, potentially impacting patient recovery and safety. Ethically, it demonstrates a lack of critical thinking and patient-centered decision-making. A third incorrect approach that indiscriminately uses antihypertensives to manage any intraoperative blood pressure fluctuation without a thorough assessment of the underlying cause or the patient's hemodynamic status is also problematic. This can lead to profound hypotension, hypoperfusion, and organ damage, representing a significant breach of professional duty and potentially violating standards of care that mandate a systematic approach to hemodynamic management. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's pre-anesthetic status, the anticipated surgical stress, and the pharmacologic properties of available anesthetic adjuncts. CRNA should consult current literature, institutional guidelines, and consider the cost-effectiveness in terms of both drug acquisition and potential for adverse events and subsequent management. This iterative process ensures that the chosen adjuncts optimize patient safety, facilitate smooth anesthesia, and contribute to efficient resource utilization. Question 8. Research into optimizing mechanical ventilation for a patient with acute respiratory distress syndrome (ARDS) has identified several potential strategies. Considering the principles of lung anatomy, gas exchange, and mechanics of breathing, which of the following approaches represents the most effective and safest method to improve oxygenation and ventilation while minimizing ventilator-induced lung injury, VILI? Option A. Aggressively increase tidal volume to ensure adequate CO2 removal, even if it leads to higher peak airway pressures. Option B. Significantly reduce PEEP to lower peak airway pressures, prioritizing pressure reduction over alveolar recruitment. Option C. Gradually increase positive end expiratory pressure, PEEP, while monitoring for alveolar recruitment using lung ultrasound and maintaining tidal volumes within lung protective limits, adjusting respiratory rate as needed for CO2 clearance. Option D. Solely increase the fraction of inspired oxygen, FiO2, to achieve target oxygen saturation without altering other ventilator parameters. The correct answer is C. Gradually increase positive end expiratory pressure, PEEP, while monitoring for alveolar recruitment using lung ultrasound and maintaining tidal volumes within lung protective limits, adjusting respiratory rate as needed for CO2 clearance. Explanation. Scenario analysis. This scenario presents a challenge in optimizing respiratory mechanics during mechanical ventilation for a patient with severe ARDS. The CRNA must balance the need to improve oxygenation and reduce lung injury with the potential for barotrauma and hemodynamic compromise. The complexity arises from the interconnectedness of ventilator settings, lung compliance, airway pressures, and patient physiology, requiring a nuanced understanding of gas exchange and breathing mechanics. Correct approach analysis. The correct approach focuses on a systematic, evidence-based strategy to improve oxygenation and ventilation while minimizing ventilator-induced lung injury, VILI. This involves titrating positive end expiratory pressure, PEEP, based on lung recruitment and oxygenation, while maintaining tidal volumes within lung protective limits and adjusting respiratory rate to manage CO2. This aligns with current CRNA practice guidelines and recommendations from professional organizations, emphasizing a patient-centered approach that prioritizes VILI prevention and optimal gas exchange. The use of lung ultrasound to assess for alveolar recruitment is a modern, evidence-based technique that aids in personalized PEEP titration, reflecting advanced CRNA practice. Incorrect approaches analysis. One incorrect approach involves solely increasing the fraction of inspired oxygen, FiO2, without addressing the underlying mechanical issues. While this may temporarily improve oxygenation, it does not address potential VILI from high peak airway pressures or inadequate alveolar recruitment, and can lead to oxygen toxicity. This fails to adhere to best practices for VILI prevention. Another incorrect approach is to aggressively increase tidal volume to improve CO2 removal. This directly contradicts lung protective ventilation strategies, significantly increasing the risk of barotrauma, volatrauma, and VILI, which is a major ethical and regulatory concern for CRNA. A third incorrect approach is to reduce PEEP significantly to decrease peak airway pressures without considering its impact on alveolar recruitment and oxygenation. This can lead to derecruitment of alveoli, worsening VILI and hypoxemia, and is not a systematic or evidence-based method for managing ARDS. Professional reasoning. CRNA must employ a systematic decision-making process when managing mechanical ventilation in complex patients. This involves 1. Initial assessment of the patient's respiratory status and underlying pathology. 2. Application of evidence-based lung-protective ventilation strategies, including appropriate PEEP and tidal volume settings. 3. Continuous monitoring of physiological parameters, e.g., SpO2, ECO2, airway pressures compliance. 4. Titration of ventilator settings based on patient response and the goal of optimizing gas exchange while minimizing villi. 5. Consideration of adjunctive therapies and advanced monitoring techniques, such as lung ultrasound, when indicated. This structured approach ensures patient safety and adherence to professional standards of care. Question 9. The monitoring system demonstrates a patient recovering from a surgical procedure with moderate incisional pain. The patient has a documented history of chronic kidney disease with a baseline serum creatinine of 1.8 mg/dl. The anesthesia provider is considering non-opioid analgesics to manage the patient's pain. Which of the following approaches best balances effective analgesia with the patient's renal status? Option A. Administer acetaminophen 1000 mg every 6 hours. Option B. Administer gabapentin 300 mg orally every 8 hours. Option C. Administer celecoxib 200 mg orally once daily. Option D. Administer ketorolac 30 mg intravenously every 6 hours. The correct answer is A. Administer acetaminophen 1000 mg every 6 hours. Explanation: Scenario analysis. This scenario presents a common clinical challenge involving the management of postoperative pain in a patient with a history of renal insufficiency. The CRNA must balance effective analgesia with the potential for adverse effects, particularly nephrotoxicity associated with NSAID. Challenge lies in selecting an appropriate non-opioid analgesic that minimizes risk while maximizing patient comfort, adhering to evidence-based practice and patient-specific factors. The presence of renal insufficiency necessitates a cautious approach to medications that can impact renal function. Correct approach analysis. The correct approach prioritizes patient safety by selecting an analgesic with a lower risk profile for renal impairment. Acetaminophen, when used within recommended dosages, is generally considered safer for patients with renal insufficiency compared to NSAID. It exerts its analgesic effect centrally and has minimal peripheral anti-inflammatory action, thus avoiding the direct inhibition of prostaglandin synthesis in the kidneys that NSAID cause. This approach aligns with the principle of do no harm and adheres to best practices for medication selection in vulnerable patient populations, as supported by current clinical guidelines and pharmacologic principles. Incorrect approaches analysis. Administering a standard dose of a non-selective NSAID like ibuprofen or ketorolac would be an incorrect approach. NSAID inhibits cyclooxygenase COX enzymes, which are crucial for prostaglandin synthesis. Prostaglandins play a vital role in maintaining renal blood flow and glomerular filtration rate, especially in individuals with compromised renal function or conditions that predispose to renal hypoperfusion. Blocking these prostaglandins can lead to acute kidney injury, exacerbation of existing renal disease, and fluid and electrolyte imbalances. This directly contravenes the CRNA ethical and professional responsibility to avoid iatrogenic harm and violates principles of safe medication management. Another incorrect approach would be to administer a COX-2 selective NSAID without careful consideration. While COX-2 inhibitors may have a slightly lower risk of gastrointestinal side effects compared to non-selective NSAID, they still carry a significant risk of renal impairment by affecting renal prostaglandin synthesis. Their use in patients with pre-existing renal insufficiency is generally discouraged or requires very careful monitoring and risk-benefit assessment, which is not implied as the primary consideration in this scenario. A third incorrect approach would be to solely rely on adjuvant medications without addressing the primary pain management need with an appropriate analgesic. While adjuvants like gabapentin or pregabalin can be useful in multimodal analgesia, they are typically used in conjunction with, not as a replacement for, primary analgesics like acetaminophen or opioids. Their efficacy for acute postoperative pain alone might be insufficient, and their selection should be guided by the type of pain and patient factors, not as a default to avoid other analgesics. Professional reasoning. Professionals should employ a systematic decision-making process that begins with a thorough patient assessment, including a detailed medical history, review of laboratory values, e.g., creatinine, BUN, and identification of any contraindications or precautions. This is followed by an evaluation of the pain characteristics and the available analgesic options. The CRNA must then weigh the potential benefits of each analgesic against its risks, considering the patient's specific comorbidities and physiological status. Evidence-based guidelines and pharmacologic principles should guide the selection. In this case, the presence of renal insufficiency strongly favors acetaminophen over NSAID. If pain control remains inadequate with acetaminophen, the CRNA should consider escalating to other modalities or consulting with the anesthesia provider or physician for further management, rather than proceeding with a higher-risk medication. Question 10. The audit findings indicate a consistent pattern of administering a specific opioid analgesic at a dosage range significantly outside the recommended therapeutic window for a particular patient population, without documented justification for the deviation. Option A. Dismiss the audit findings as a minor discrepancy, given that no immediate adverse patient events were reported during the audited period. Option B. Immediately adjust the documentation to reflect the recommended therapeutic dosage, assuming the audit reflects a clerical error rather than a clinical practice deviation. Option C. Initiate a comprehensive review of the audit data, consult current evidence-based guidelines and institutional protocols for the administration of this opioid, and engage in a collaborative discussion with the anesthesia team to understand the rationale behind the observed practice and identify any potential contributing factors. Option D. Implement a blanket policy chain to restrict the use of this opioid analgesic for all patients within that population, without further investigation into the specific circumstances of the audit findings. The correct answer is C. Initiate a comprehensive review of the audit data, consult current evidence-based guidelines and institutional protocols for the administration of this opioid, and engage in a collaborative discussion with the anesthesia team to understand the rationale behind the observed practice and identify any potential contributing factors. Explanation. Scenario analysis. This scenario presents a professional challenge due to the potential for adverse patient outcomes stemming from a deviation in standard pharmacological practice. The CRNA must reconcile audit findings with their clinical judgment and established protocols, ensuring patient safety remains paramount while addressing systemic or individual performance issues. The challenge lies in identifying the root cause of the discrepancy and implementing appropriate corrective actions without compromising patient care or professional integrity. Correct approach analysis. The correct approach prioritizes patient safety and adherence to evidence-based practice and regulatory guidelines. It involves a thorough review of the audit findings, consultation with relevant literature and institutional policies, and a collaborative discussion with the anesthesia team. This approach ensures that any identified deviations are understood in context, potential risks are mitigated, and practice is aligned with current standards of care and the Nurse Anesthesia Practice Act, as well as relevant state and federal regulations governing controlled substances and medication administration. This aligns with the CRNA ethical obligation to provide safe and effective anesthesia care and their professional responsibility to maintain competence. Incorrect approaches analysis. One incorrect approach would be to dismiss the audit findings without further investigation, assuming the observed practice was clinically justified. This fails to acknowledge the potential for error or suboptimal care, directly contravening the CRNA duty to ensure safe practice and potentially violating regulations that mandate quality assurance and performance improvement. It also ignores the ethical imperative to be accountable for one's practice. Another incorrect approach would be to immediately implement punitive measures without a comprehensive understanding of the situation. This bypasses the critical step of root cause analysis, which is essential for identifying systemic issues versus individual performance problems. Such an approach could lead to unnecessary disciplinary actions, damage team morale, and fail to address the underlying cause of the deviation, thus not improving patient safety in the long term. It also disregards the principles of due process and professional development. A third incorrect approach would be to alter documentation retrospectively to align with the audit findings without a corresponding change in actual practice. This constitutes falsification of records, a serious ethical and legal violation that undermines the integrity of patient care documentation and can have severe consequences, including loss of licensure. It directly violates regulations concerning accurate record keeping and the ethical principles of honesty and transparency. Professional reasoning. Professionals facing such a situation should employ a systematic decision-making framework. First, they must acknowledge and thoroughly investigate the audit findings, gathering all relevant data. Second, they should consult established guidelines, institutional policies, and peer-reviewed literature to understand best practices related to the observed deviation. Third, they should engage in open and honest communication with the involved parties, including colleagues and supervisors, to discuss the findings and potential causes. Fourth, they must assess the impact on patient safety and implement evidence-based interventions to correct any identified deficiencies. Finally, they should document the process and outcomes, ensuring continuous quality improvement and adherence to all applicable regulations and ethical standards. Question 11. Which approach would be most appropriate for a CRNA to ensure optimal patient safety and anesthetic effectiveness when considering the human anatomy relevant to a planned surgical procedure? Option A. Delegating the critical anatomical assessment solely to the surgical team without independent CRNA verification. Option B. A systematic assessment of the patient's individual anatomy, considering variations and potential implications for anesthetic management and complication avoidance. Option C. Relying primarily on generalized anatomical diagrams and textbook descriptions without specific patient-centered evaluation. Option D. Disregarding patient-reported anatomical anomalies or previous difficulties with anesthetic interventions. The correct answer is B. A systematic assessment of the patient's individual anatomy, considering variations and potential implications for anesthetic management and complication avoidance. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the certified registered nurse anesthetist (CRNA) to integrate a deep understanding of human anatomy with the immediate needs of a patient undergoing a complex surgical procedure. The CRNA must anticipate potential anatomical variations and their implications for airway management, vascular access, and regional anesthesia techniques. Failure to accurately assess and apply anatomical knowledge can lead to critical patient safety events, including airway compromise, nerve injury, or inadequate anesthesia. The CRNA judgment is paramount in selecting and executing anesthetic techniques that are both effective and safe, directly correlating with their anatomical expertise. Correct approach analysis. The correct approach involves a systematic assessment of the patient's relevant anatomy, considering factors such as body habitus, previous surgical history, and potential anatomical distortions. This assessment informs the CRNA selection of the most appropriate anesthetic technique and aids in anticipating potential complications. For example, understanding the precise location of the cricothyroid membrane and surrounding structures is crucial for a successful cricothyroidotomy if emergent airway access is required. Similarly, knowledge of the vertebral column's anatomy, including interspinous spaces and ligamentous structures, is fundamental for safe and effective spinal or epidural anesthesia. This approach aligns with the CRNA scope of practice, as defined by the American Association of Nurse Anesthetists, ANA, practice standards, which emphasize the importance of a thorough pre-anesthetic evaluation and the application of scientific knowledge to patient care. Best professional practice dictates that all anesthetic decisions are grounded in a comprehensive understanding of patient anatomy and physiology to ensure optimal outcomes and patient safety. Incorrect approach is analysis. An approach that relies solely on rote memorization of anatomical diagrams without considering individual patient variations would be professionally unacceptable. This fails to account for the fact that anatomical structures can differ significantly between individuals due to genetics, disease, or prior interventions. Such an approach could lead to incorrect landmark identification for regional blocks or misjudgment of airway anatomy, potentially resulting in nerve damage or airway obstruction. This violates the ethical principle of beneficence, as it increases the risk of harm to the patient. Another incorrect approach would be to delegate the primary anatomical assessment to another member of the surgical team without independent CRNA verification. While collaboration is essential, the CRNA is ultimately responsible for the anesthetic plan and its safe execution. Abdicating this responsibility based on another's assessment, without critical evaluation, could lead to critical oversights in anesthetic management. This represents a failure to adhere to professional accountability and the CRNA duty of care. A third incorrect approach would be to disregard patient-reported anatomical concerns, such as a history of difficult intubations or prior nerve injuries, during the pre-anesthetic assessment. Such information is vital for tailoring the anesthetic plan and anticipating potential challenges. Ignoring these patient-specific anatomical considerations increases the likelihood of adverse events and demonstrates a lack of patient-centered care, which is a cornerstone of ethical nursing practice. Professional reasoning. Professionals should employ a decision-making process that begins with a comprehensive pre-anesthetic evaluation, integrating patient history, physical examination, and diagnostic data. This evaluation must include a detailed assessment of relevant anatomy for the planned procedure. The CRNA should then synthesize this anatomical information with the patient's overall physiological status and the surgical plan to formulate a safe and effective anesthetic strategy. This strategy should include contingency plans for anticipated anatomical challenges or complications. Continuous reassessment of the patient's anatomy and response to anesthesia throughout the procedure is also critical. This systematic, patient-specific, and evidence-based approach ensures that the CRNA is providing the highest standard of care, adhering to regulatory requirements and ethical obligations. Question 12. The review process indicates a patient scheduled for elective surgery is taking a novel anticoagulant medication that has limited published data regarding its interaction with commonly used anesthetic agents. What is the most appropriate course of action for the Certified Registered Nurse Anesthetist, CRNA, to ensure patient safety regarding potential drug interactions? Option A. Administer standard anesthetic agents and closely monitor the patient for any signs of adverse reactions, intervening only if a problem arises. Option B. Inform the patient that the anticoagulant poses an unknown risk and suggest postponing the surgery until more information is available without further investigation. Option C. Conduct a thorough review of the patient's medical history and current medications. Consult evidence-based drug interaction databases and pharmacological references, and collaborate with the anesthesiologist and potentially a pharmacist to develop a tailored anesthetic plan that mitigates identified risks. Option D. Proceed with the planned anesthetic, relying on the anesthesiologist's experience and assuming no significant interaction will occur due to the lack of reported cases. The correct answer is D. Proceed with the planned anesthetic, relying on the anesthesiologist's experience and assuming no significant interaction will occur due to the lack of reported cases. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the Certified Registered Nurse Anesthetist, CRNA, to anticipate and manage potential drug interactions that could significantly impact patient safety during anesthesia. The CRNA must possess a comprehensive understanding of pharmacodynamics and pharmacokinetics, not only of anesthetic agents, but also of the patient's current medications. Failure to identify and address these interactions can lead to unpredictable and potentially life-threatening adverse events, such as exaggerated anesthetic effects, cardiovascular instability, or prolonged recovery. The CRNA responsibility extends beyond administering drugs to actively monitoring for and mitigating risks associated with their combined use. Correct approach analysis. The correct approach involves a thorough pre-anesthetic assessment that includes a detailed review of the patient's current medication list. This review should specifically identify medications known to interact with anesthetic agents or other perioperative drugs. The CRNA must then consult reliable, evidence-based resources, e.g., drug interaction databases, pharmacological references, institutional guidelines, to understand the nature and potential severity of any identified interactions. Based on this information, the CRNA should develop a tailored anesthetic plan that either avoids specific drug combinations, modifies dosages, implements closer monitoring, or prepares for potential interventions. This proactive and informed approach aligns with the CRNA ethical and professional obligation to provide safe and individualized patient care. As mandated by standards of practice and regulatory bodies governing nurse anesthesia in the United States, the American Association of Nurse Anesthesiology, A4NA Standards for Nurse Anesthesia Practice, emphasize the importance of patient assessment and the development of an individualized anesthesia plan, which inherently includes managing drug interactions. Incorrect approach is analysis. One incorrect approach is to assume that if a patient has been taking a medication without apparent issues prior to surgery, it will not interact with anesthetic agents. This is a failure to recognize that the perioperative environment and the administration of potent anesthetic drugs create a unique physiological state where previously unrecognized or insignificant interactions can become clinically relevant and dangerous. This approach violates the principle of due diligence and the CRNA responsibility to anticipate potential complications. Another incorrect approach is to rely solely on the anesthesiologist's assessment without independently verifying potential drug interactions. While collaboration is crucial, the CRNA has a distinct role and responsibility in patient assessment and anesthetic management. Delegating this critical aspect of risk assessment entirely to another provider without personal verification can lead to missed interactions and represents a lapse in professional accountability. This can be seen as a failure to adhere to the A4NA standards, which outline the CRNA direct responsibility for patient care. A third incorrect approach is to administer anesthetic agents without considering the patient's current pharmacological regimen, only addressing potential interactions if an adverse event occurs. This reactive approach is contrary to best practices in anesthesia and patient safety. It demonstrates a lack of foresight and a failure to implement preventative measures, which is a fundamental aspect of safe anesthesia practice. This approach directly contravenes the proactive risk management expected of CRNA and can be considered a deviation from the standard of care. Professional reasoning. Professionals should employ a systematic decision-making process that prioritizes patient safety. This involves 1. Comprehensive patient assessment, thoroughly reviewing the patient's medical history, allergies, and all current medications, including over-the-counter drugs and herbal supplements. 2. Risk identification, actively identifying potential drug interactions between the patient's current medications and planned anesthetic agents or perioperative drugs. 3. Evidence-based consultation, utilizing reliable drug interaction resources and consulting with pharmacists or physicians when necessary. 4. Anesthetic plan development, creating an individualized anesthesia plan that accounts for identified interactions, including potential modifications to drug choices, dosages, or monitoring strategies. 5. Continuous monitoring and reassessment, vigilantly monitoring the patient for signs of adverse drug interactions throughout the perioperative period and being prepared to intervene promptly. This structured approach ensures that potential risks are identified and managed proactively, aligning with ethical obligations and regulatory requirements for safe anesthesia practice. Question 13. The analysis reveals a 72-year-old male patient with a history of chronic kidney disease, CKD stage 4, scheduled for a laparoscopic cholecystectomy. The patient's baseline serum creatinine is 2.5 mg/dl and BUN is 45 mg/dl. The anesthetist is considering anesthetic agents for induction and maintenance. Which of the following approaches best addresses the pharmacokinetic implications of the patient's renal impairment? Option A. Utilize a volatile anesthetic agent exclusively, without considering the potential for accumulation due to reduced clearance of its metabolites. Option B. Choose an anesthetic agent known to be renally cleared, assuming that the patient's overall health status will compensate for the impaired excretion. Option C. Administer standard doses of commonly used intravenous anesthetic agents and rely on extended postoperative monitoring for signs of prolonged effect. Option D. Select an induction agent and maintenance agent that are primarily metabolized by the liver and have minimal renal excretion, or are readily reversible. Correct answer is D. Select an induction agent and maintenance agent that are primarily metabolized by the liver and have minimal renal excretion, or are readily reversible. Explanation. Scenario analysis. This scenario presents a common clinical challenge involving a patient with compromised renal function undergoing anesthesia. The anesthetist must anticipate how altered pharmacokinetics, specifically impaired excretion, will affect the duration and intensity of anesthetic agents. Failure to account for this can lead to prolonged recovery, increased risk of adverse events, and potential organ damage. The professional challenge lies in applying theoretical pharmacokinetic principles to a real-time clinical situation with a vulnerable patient population, requiring a nuanced understanding beyond simple drug dosages. Correct approach analysis. The correct approach involves selecting anesthetic agents with minimal reliance on renal excretion for elimination, or agents that can be reversed effectively if prolonged effects are anticipated. This aligns with the CRNA responsibility under the Nurse Anesthesia Practice Act and the American Association of Nurse Anesthetists, ANA, Code of Ethics to provide safe and individualized patient care. Prioritizing agents with predictable clearance through hepatic metabolism or direct reversal agents demonstrates a commitment to patient safety by mitigating the risks associated with impaired renal function. This proactive approach minimizes the potential for drug accumulation and its sequelae. Incorrect approach is analysis. Choosing an anesthetic agent primarily cleared by the kidneys without considering the patient's renal impairment is a direct violation of the standard of care and potentially the Nurse Anesthesia Practice Act. This failure to individualize care based on patient-specific factors constitutes negligence. Administering a standard dose of a renally cleared agent and relying solely on prolonged monitoring without adjusting the agent selection or anticipating the need for intervention is also professionally unacceptable. This passive approach ignores the predictable pharmacokinetic changes and increases the risk of adverse outcomes, failing to meet the ethical obligation of vigilance and proactive patient management. Assuming that all anesthetic agents are unaffected by renal impairment demonstrates a fundamental misunderstanding of pharmacokinetics and a failure to adhere to evidence-based practice guidelines, which are implicitly expected under professional standards. This lack of knowledge or application of knowledge can lead to significant patient harm. Professional reasoning. When faced with a patient with altered organ function, the professional decision-making process should begin with a thorough patient assessment, including a review of laboratory data, e.g., creatinine clearance. This assessment should then inform the selection of anesthetic agents, prioritizing those with pharmacokinetic profiles that are least likely to be adversely affected by the patient's condition. If agents with potential for accumulation are necessary, strategies for dose adjustment, prolonged monitoring, and prompt intervention, including reversal agents, must be pre-planned. This systematic approach, grounded in patient-specific data and pharmacokinetic principles, ensures the delivery of safe and effective anesthesia, adhering to both regulatory requirements and ethical obligations. Question 14. Compliance review shows a certified registered nurse anesthetist, CRNA, is preparing to administer a regional anesthetic for a lower extremity surgery. The patient has a history of poorly controlled hypertension and a recent diagnosis of a bleeding disorder. The CRNA is considering a spinal anesthetic, an epidural anesthetic, or a peripheral nerve block. Which of the following approaches best reflects adherence to current U.S. regulatory frameworks and best professional practice for this patient? Option A. Proceed with a spinal anesthetic, as it offers rapid onset and profound analgesia, and monitor the patient closely for any signs of bleeding complications. Option B. Administer a peripheral nerve block using ultrasound guidance after a thorough pre-anesthetic assessment, including consultation with hematology regarding the bleeding disorder and optimization of the patient's hypertension. Option C. Perform a landmark-based peripheral nerve block, as it is a faster technique and the bleeding disorder is unlikely to significantly impact this type of block. Option D. Administer an epidural anesthetic, as it allows for titration of analgesia and can be converted to a general anesthetic if complications arise, without significant concern for the bleeding disorder. Correct answer is B. Administer a peripheral nerve block using ultrasound guidance after a thorough pre-anesthetic assessment, including consultation with hematology regarding the bleeding disorder and optimization of the patient's hypertension. Explanation. This scenario presents a professional challenge due to the inherent risks associated with regional anesthesia and the critical need for adherence to established standards of care and patient safety protocols. The CRNA must balance the benefits of regional techniques with the potential for complications, requiring meticulous patient assessment, precise technique, and vigilant monitoring. The challenge lies in anticipating and mitigating adverse events while ensuring optimal patient outcomes, all within the strict regulatory framework governing nurse anesthesia practice. The correct approach represents best professional practice because it prioritizes patient safety and evidence-based care, aligning with the standards set forth by the American Association of Nurse Anesthesiology (ANA), and the Nurse Anesthesia Practice Act of the relevant U.S. jurisdiction. This approach emphasizes thorough pre-anesthetic evaluation, including a detailed assessment of patient history, physical examination, and consideration of contraindications specific to regional anesthesia. It mandates the use of aseptic technique, appropriate equipment, and accurate landmark identification or ultrasound guidance to minimize the risk of infection, nerve injury, or vascular puncture. Furthermore, it underscores the importance of appropriate dosing, titration, and continuous monitoring of vital signs and neurological status throughout the procedure and into the post-anesthesia period, ensuring prompt recognition and management of any complications. This aligns with the CRNA ethical and legal responsibility to provide safe and effective anesthesia care. An incorrect approach that involves proceeding with a spinal anesthetic in a patient with a known bleeding disorder without appropriate consultation or correction of the coagulopathy represents a significant regulatory and ethical failure. This directly violates the principle of beneficence and non-maleficence, as it exposes the patient to an unacceptably high risk of spinal hematoma, a potentially devastating complication. Such an action would contraindicate the CRNA adherence to established practice guidelines and potentially violate state nurse practice acts that require practice within the scope of competence and adherence to standards of care. Another incorrect approach, such as performing a peripheral nerve block without adequate visualization or anatomical knowledge, leading to inadvertent vascular injection or nerve trauma, demonstrates a failure to uphold the standard of care. This could be considered a breach of professional duty and a violation of the CRNA responsibility to employ techniques that minimize harm. Regulatory bodies would view this as a failure to practice competently and safely. A third incorrect approach, such as administering an epidural anesthetic without confirming correct needle placement through aspiration or observing cerebrospinal fluid, CSF, or blood, and then proceeding with medication, poses a grave risk of intrathecal or intravascular injection. This is a direct contravention of fundamental epidural technique and safety protocols, leading to potential systemic toxicity or inadequate analgesia. This failure to follow established safety checks would be a clear violation of practice standards and could result in disciplinary action. Professional decision-making in similar situations requires a systematic approach. First, a comprehensive assessment of the patient and the planned procedure is paramount. Second, the CRNA must critically evaluate potential risks and benefits, considering patient-specific factors and contraindications. Third, adherence to established evidence-based guidelines and institutional protocols is non-negotiable. Fourth, the CRNA must possess and demonstrate the necessary skills and knowledge for the chosen anesthetic technique, utilizing advanced tools like ultrasound when indicated. Finally, continuous vigilance, clear communication with the surgical team, and a commitment to patient advocacy are essential for ensuring safe and effective anesthesia care. Question 15. The risk matrix shows a moderate likelihood of airway compromise during rapid sequence induction in a patient with a history of obstructive sleep apnea and a BMI of 38, who is requesting a rapid induction to minimize intraoperative awareness. The CRNA has identified a safer, albeit slightly slower, induction technique that significantly reduces the risk of airway compromise. What is the most appropriate course of action? Option A. Proceed with the patient's requested rapid induction, documenting the patient's informed consent for the increased risk of airway compromise. Option B. Refuse the patient's request for rapid induction outright, stating that it is unsafe, and proceed with a standard induction technique without further discussion. Option C. Document the patient's request for rapid induction and their refusal of the CRNA recommendation for a slower technique. Then proceed with the patient's preferred method. Option D. Discuss the identified risks of the patient's requested rapid induction. Explain the benefits of the alternative technique in mitigating these specific risks, and collaboratively develop an anesthetic plan that addresses the patient's concerns about awareness while prioritizing airway safety. The correct answer is D. Discuss the identified risks of the patient's requested rapid induction, explain the benefits of the alternative technique in mitigating these specific risks, and collaboratively develop an anesthetic plan that addresses the patient's concerns about awareness while prioritizing airway safety. Explanation. This scenario presents a professional challenge due to the inherent conflict between patient autonomy, beneficence, and the CRNA professional responsibility to ensure safe anesthetic care. The patient stated preference for a rapid induction, despite the CRNA assessment of increased risk, creates a complex ethical and clinical dilemma. Careful judgment is required to balance the patient's wishes with the CRNA duty to prevent harm. The correct approach represents best professional practice because it prioritizes patient safety while still respecting patient autonomy to a reasonable degree. The CRNA responsibility under the Nurse Anesthesia Practice Act, NAPA, and the American Association of Nurse Anesthetists, ANA, Code of Ethics is to provide safe and effective anesthesia care. This involves a thorough pre-anesthetic assessment, identifying potential risks, and developing an anesthetic plan that mitigates those risks. When a patient's request directly conflicts with the CRNA professional judgment regarding safety, the CRNA must advocate for the safest course of action. This approach involves open communication with the patient, explaining the risks associated with their preferred method, and proposing an alternative that achieves the desired outcome with a lower risk profile. This aligns with the principle of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm. An incorrect approach that involves proceeding with the patient's requested rapid induction without further discussion or modification would be a failure to uphold the CRNA duty of care. This would violate the NAPA requirement for competent practice and the ANA Code of Ethics emphasis on patient safety and professional judgment. It could be construed as negligence if adverse outcomes occur due to the increased risk. Another incorrect approach, rigidly refusing the patient's request without adequate explanation or exploration of alternatives, would fail to respect patient autonomy and could damage the therapeutic relationship. While patient safety is paramount, a collaborative approach that educates the patient and seeks a mutually agreeable plan is ideal. This would fall short of the ethical obligation to involve the patient in decision-making to the extent possible, as outlined in ethical guidelines. A third incorrect approach, documenting the patient's refusal of the CRNA recommendation without a clear plan to manage the identified risks, would be a failure in documentation and communication. It leaves the patient vulnerable and does not demonstrate a proactive approach to managing the situation. Professional decision-making in such situations requires a systematic process. 1. Assess the patient and identify risks. 2. Communicate risks and benefits clearly to the patient. 3. Explore alternatives and seek patient input. 4. Formulate a plan that prioritizes safety while respecting autonomy. 5. Document the discussion and the agreed-upon plan. Question 16. During the evaluation of a 4-year-old child emerging from general anesthesia for a tonsillectomy, the CRNA observes the child thrashing in bed, crying inconsolably, and attempting to pull out their Roman 4 line. The child's vital signs are stable, oxygen saturation is 98% on room air, and temperature is 37.0 degrees C. The CRNA suspects emergence delirium. Which of the following actions is the most appropriate initial management strategy? Option A. Immediately notify the surgeon and anesthesiologist that the child is experiencing severe emergence delirium and requires immediate transfer back to the operating room. Option B. Administer a bolus of intravenous midazolam to sedate the child and reduce agitation. Option C. Apply physical restraints to prevent the child from harming themselves and wait for the agitation to subside naturally. Option D. Gently restrain the child, speak in a calm and reassuring voice, and assess for potential sources of discomfort such as pain, bladder distension, or a loose dressing. The correct answer is D. Gently restrain the child, speak in a calm and reassuring voice, and assess for potential sources of discomfort such as pain, bladder distension, or a loose dressing. Explanation. This scenario presents a common yet critical challenge in post-anesthesia care, recognizing and managing emergent delirium in a pediatric patient. The professional challenge lies in differentiating between expected emergence phenomena and a more serious underlying complication, requiring a systematic and evidence-based approach. The certified registered nurse anesthetist, CRNA, must possess a high degree of clinical acumen to interpret subtle signs and symptoms, consider differential diagnoses, and initiate appropriate interventions promptly. The correct approach represents best professional practice by prioritizing patient safety and adhering to established post-anesthesia care standards as outlined by the American Association of Nurse Anesthesiology ANA guidelines for post-anesthesia care. This involves a comprehensive assessment of the patient's airway, breathing, circulation, neurological status, and pain level, specifically recognizing the signs of emergence delirium, e.g., agitation, confusion, crying, thrashing, and systematically ruling out other potential causes such as hypoxia, hypoglycemia, pain, or bladder distension is paramount. Promptly addressing reversible causes and providing a calm, reassuring environment are key components of effective management. An incorrect approach that involves immediate physical restraint without a thorough assessment fails to uphold professional ethical obligations and regulatory requirements. Such an action could exacerbate the patient's distress, mask underlying physiological issues, and potentially lead to injury. This violates the principle of beneficence and non-maleficence, as it prioritizes control over patient well-being and could be construed as a failure to provide appropriate care as mandated by state nurse practice acts and ANA standards. Another incorrect approach, such as administering a sedative without first identifying and addressing potential underlying physiological causes of agitation, is also professionally unacceptable. This bypasses the critical step of differential diagnosis and could mask a serious condition like hypoxia or hypoglycemia, delaying life-saving interventions. This represents a deviation from best practice and could lead to adverse patient outcomes, potentially violating standards of care and professional accountability. Furthermore, an approach that involves delaying further assessment and intervention based on the assumption that the behavior is simply part of waking up is a significant failure. Post-anesthesia care requires continuous vigilance and reassessment. Ignoring or downplaying concerning symptoms can lead to misdiagnoses and delayed treatment, which is contrary to the CRNA responsibility to monitor and manage the patient's recovery. This demonstrates a lack of adherence to the dynamic nature of post-anesthesia recovery and the need for ongoing clinical judgment. The professional decision-making process for similar situations should involve a structured, systematic approach. 1. Initial assessment. Perform a rapid head-to-toe assessment focusing on ABC's airway, breathing, circulation, vital signs, and neurological status. 2. Identify the problem. Recognize and document the patient's specific signs and symptoms of agitation or distress. 3. Differential diagnosis. Systematically consider and rule out common reversible causes of post-anesthesia agitation, including pain, hypoxia, hypercapnia, hypoglycemia, hypothermia, bladder distension, and medication side effects. 4. Intervention. Implement targeted interventions based on the identified cause. This may include administering analgesics, providing supplemental oxygen, correcting fluid/electrolyte imbalances, or addressing other physiological derangements. 5. Reassessment. Continuously monitor the patient's response to interventions and reassess their condition. 6. Communication. Communicate findings and interventions to the surgical team and other relevant healthcare providers. 7. Documentation. Accurately document all assessments, interventions, and patient responses. Question 17. The audit findings indicate a discrepancy in the pre-anesthetic evaluation documentation for a patient with severe, uncontrolled hypertension and a history of obstructive sleep apnea scheduled for a minor surgical procedure. The patient has explicitly requested a specific anesthetic technique that, based on their comorbidities, carries a significantly elevated risk of perioperative cardiovascular and respiratory compromise. The CRNA is faced with the patient's autonomy versus the professional obligation to ensure patient safety. What is the most appropriate course of action? Option A. Proceed with the patient's requested anesthetic technique, documenting their informed consent, as patient autonomy is the highest ethical consideration. Option B. Refuse to administer the requested anesthetic technique and insist on a different approach without further discussion, citing the elevated risks as an absolute contraindication. Option C. Delay the procedure to allow for further optimization of the patient's comorbidities and engage in a detailed discussion with the patient and surgical team about alternative anesthetic plans that mitigate identified risks. Option D. Administer the requested anesthetic technique, but closely monitor the patient with advanced hemodynamic and respiratory monitoring, accepting the increased risk as part of providing patient-centered care. The correct answer is A. Proceed with the patient's requested anesthetic technique, documenting their informed consent, as patient autonomy is the highest ethical consideration. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's stated wishes and the CRNA professional judgment regarding patient safety, particularly when comorbidities significantly increase anesthetic risk. The CRNA must navigate ethical principles of autonomy, beneficence, non-maleficence, and justice, while adhering to the standards of practice and scope of practice as defined by the relevant U.S. regulatory framework for certified registered nurse anesthetists. The audit findings highlight a potential deviation from established protocols and a need for careful consideration of the patient's complex physiological state. The correct approach represents best professional practice because it prioritizes patient safety and well-being, aligning with the CRNA ethical and legal obligations. It involves a comprehensive assessment, clear communication with the patient and the surgical team, and a collaborative decision-making process that seeks to balance patient autonomy with the CRNA duty to prevent harm. This approach upholds the standards of care by ensuring that the anesthetic plan is tailored to the patient's specific comorbidities and that all parties are informed and in agreement regarding the risks and benefits. This aligns with the ethical principles of beneficence and non-maleficence, ensuring the patient receives the safest possible anesthetic care. An incorrect approach that involves proceeding with the patient's requested anesthetic plan without further discussion or modification would be a significant regulatory and ethical failure. This would violate the principle of non-maleficence by knowingly exposing the patient to an unacceptable level of risk due to their unmanaged comorbidities. It could also be seen as a failure to uphold the standards of practice, which mandate a thorough pre-anesthetic evaluation and the development of an anesthetic plan appropriate for the patient's condition. Furthermore, it disregards the CRNA professional responsibility to advocate for the patient's safety, even when it conflicts with the patient's initial request. Another incorrect approach, such as unilaterally refusing to administer any anesthesia without adequate exploration of alternatives or consultation, could be seen as a failure to respect patient autonomy and a potential breach of the duty to provide care. While safety is paramount, a complete refusal without attempting to find a mutually agreeable solution or explore alternative anesthetic techniques or risk mitigation strategies may not be the most ethically sound or professionally appropriate first step. It could also lead to a breakdown in the patient-provider relationship and the surgical team's trust. The professional decision-making process for similar situations should involve a systematic approach. 1. Comprehensive assessment. Thoroughly evaluate the patient's comorbidities, their impact on anesthetic management, and the potential risks associated with different anesthetic techniques. 2. Risk-benefit analysis. Clearly articulate the risks and benefits of the patient's requested anesthetic plan versus alternative plans, considering the patient's specific physiological status. 3. Patient education and shared decision-making. Engage in open and honest communication with the patient, explaining the risks in understandable terms and exploring their values and preferences. 4. Interdisciplinary collaboration. Consult with the surgeon and other members of the healthcare team to discuss the patient's condition, the proposed anesthetic plan, and any necessary modifications or alternative strategies. 5. Documentation. Meticulously document the patient's assessment, the discussions held, the rationale for the chosen anesthetic plan, and the informed consent obtained. 6. Ethical consultation. If significant ethical dilemmas persist, seek guidance from the institution's ethics committee or relevant professional bodies. Question 18. Process analysis reveals that during a preoperative assessment, a patient reports a history of occasional shortness of breath, but appears anxious and has difficulty recalling specific details about its onset, duration, or triggers. The patient's electronic medical record contains limited information regarding respiratory complaints. Given these findings, what is the most appropriate course of action for the certified registered nurse anesthetist to ensure comprehensive risk stratification? Option A. Attempt to obtain additional information by reviewing the patient's full medical record for any prior documented respiratory issues, consulting with the patient's family or caregiver if available, and conducting a thorough physical examination with a specific focus on the respiratory system. Option B. Postpone the procedure until a full pulmonary function test can be completed, as any mention of shortness of breath necessitates extensive diagnostic workup. Option C. Document the patient's reported symptoms and the limitations of the history, then proceed with the anesthetic plan without further investigation, relying on the physical examination alone. Option D. Proceed with the anesthetic plan as initially conceived, assuming the shortness of breath is solely due to preoperative anxiety and not clinically significant. Correct answer is D. Proceed with the anesthetic plan as initially conceived, assuming the shortness of breath is solely due to preoperative anxiety and not clinically significant. Explanation. Scenario analysis. This scenario presents a common challenge in preoperative assessment, where a patient's reported history is incomplete and potentially misleading due to anxiety and cognitive impairment. The Certified Registered Nurse Anesthetist, CRNA, must navigate this situation to ensure patient safety, which is paramount and a core ethical and regulatory obligation. The challenge lies in obtaining a comprehensive and accurate preoperative assessment despite patient-related barriers, necessitating critical thinking and a systematic approach to risk stratification. Correct approach analysis. The correct approach emphasizes a multifaceted strategy to gather essential information. This includes utilizing available resources such as the patient's medical record, consulting with family members or caregivers who can provide a more objective history, and conducting a thorough physical examination to identify objective signs of underlying conditions. This comprehensive approach aligns with the standards of practice for CRNA, which mandate a thorough preoperative evaluation to identify potential risks and optimize the patient for anesthesia and surgery. Regulatory frameworks, such as those established by the American Association of Nurse Anesthetists, ANA, and state boards of nursing, require CRNA to perform diligent assessments and document their findings to ensure patient safety and informed decision-making. This approach prioritizes patient well-being by mitigating the risks associated with incomplete information. Incorrect approaches analysis. One incorrect approach involves solely relying on the patient's self-reported history, especially when there are indicators of unreliability. This fails to meet the regulatory requirement for a comprehensive assessment and can lead to the omission of critical information, potentially resulting in adverse events. Ethically, it breaches the duty of care owed to the patient. Another incorrect approach is to proceed with the anesthetic plan without attempting to clarify the discrepancies or gather additional information. This demonstrates a lack of due diligence and a failure to adequately stratify risk. It disregards the professional responsibility to ensure the patient is as safe as possible for the planned procedure. A third incorrect approach might be to dismiss the patient's reported symptoms as solely due to anxiety without further investigation. While anxiety is common, it can mask or exacerbate underlying physiological issues. Failing to explore these possibilities further is a failure in critical assessment and risk identification, potentially leading to an inadequate anesthetic plan. Professional reasoning. When faced with an incomplete or unreliable patient history, the CRNA should employ a systematic decision-making process. This involves 1. Recognizing the limitations of the current information. 2. Actively seeking corroborating or additional data from all available sources, medical records, family, previous providers. 3. Performing a detailed physical examination to identify objective findings. 4. Considering the potential impact of any identified or suspected conditions on anesthetic management. 5. Documenting all findings, the rationale for decisions, and any consultations. This iterative process ensures that the anesthetic plan is based on the most complete and accurate information available, thereby upholding the highest standards of patient care and regulatory compliance. Question 19. Regulatory review indicates that the Certified Registered Nurse Anesthetist, CRNA, is responsible for ensuring patient safety prior to the administration of anesthesia. Considering the physiological impact of gastrointestinal function on anesthetic risk, which of the following preanesthetic assessment components is most critical for a CRNA to verify to mitigate the risk of aspiration in accordance with U.S. regulatory frameworks and professional guidelines? Option A. Assessment of the patient's subjective feeling of hunger or fullness prior to anesthesia. Option B. A general inquiry about the patient's usual dietary habits and preferences. Option C. Confirmation of the patient's last oral intake of clear liquids and solids and the precise timing of each in relation to the scheduled procedure. Option D. Verification of the patient's body mass index, BMI, to estimate gastric volume. The correct answer is C. Confirmation of the patient's last oral intake of clear liquids and solids and the precise timing of each in relation to the scheduled procedure. Explanation. Scenario analysis. This scenario presents a professional challenge due to the inherent variability in gastrointestinal (GI) function and its direct impact on anesthetic management. Patients may have underlying GI conditions beyond medications affecting GI motility or absorption, or have recently consumed food or liquids, all of which can influence the speed of gastric emptying and the risk of aspiration. As certified registered nurse anesthetists, CRNA, in the U.S., adherence to the American Society of Anesthesiologists, ASAG guidelines for fasting is paramount. These guidelines are not arbitrary. They are based on extensive physiological understanding and clinical experience to mitigate significant patient safety risks. The CRNA must exercise sound clinical judgment, integrating patient-specific factors with established protocol to ensure patient safety. Correct approach analysis. The correct approach involves a thorough pre-anesthetic assessment that specifically inquires about the patient's last oral intake of solids and clear liquids, and the timing of any medications that might affect gastric emptying. This aligns directly with ASA guidelines, which provide evidence-based recommendations for fasting periods to reduce the risk of pulmonary aspiration. The CRNA responsibility is to verify that the patient has met these fasting requirements before proceeding with anesthesia. This proactive assessment and adherence to established guidelines represent best professional practice, as it directly addresses a known and significant risk factor for anesthetic complications. The legal and ethical obligation of the CRNA is to provide care that meets or exceeds the standard of care, which in this context is informed by ASA guidelines. Incorrect approaches analysis. One incorrect approach is to assume that a patient's statement about feeling fine or not being hungry is sufficient to waive fasting guidelines. This fails to acknowledge the physiological reality that subjective feelings do not always correlate with gastric emptying status. Ethically, this approach prioritizes patient comfort over safety, which is a dereliction of the CRNA duty of care. Legally, it could be considered a deviation from the standard of care, potentially leading to adverse outcomes and liability. Another incorrect approach is to rely solely on the patient's self-reported last meal without further inquiry or verification, especially if the reported time is close to the scheduled procedure. This demonstrates a lack of due diligence and a failure to actively assess risk. The ASA guidelines are designed to create a buffer against variability, and bypassing this buffer based on unverified information is a significant professional and ethical lapse. A third incorrect approach is to proceed with anesthesia without confirming the type of fluid intake, e.g., clear liquids vs. solids, and the exact timing of consumption. Different types of intake have different gastric emptying times, and the ASA guidelines specify different fasting periods for each. Failing to differentiate and confirm these details means the CRNA is not applying the guidelines accurately, thereby increasing the risk of aspiration and violating professional standards. Professional reasoning. In situations involving potential GI compromise relevant to anesthesia, CRNA should employ a systematic decision-making process. This begins with a comprehensive pre-anesthetic evaluation, focusing on factors that influence gastric emptying and aspiration risk. This includes a detailed history of oral intake, type and timing, review of medications, and assessment for conditions that delay gastric emptying, e.g., diabetes, gastroparesis, opioid use. The CRNA must then apply the relevant ASA guidelines for fasting, understanding the rationale behind them. If there is any doubt or deviation from the guidelines, the CRNA should communicate with the anesthesiologist and the surgical team to discuss risk mitigation strategies, which may include delaying the procedure, using rapid sequence induction, or other interventions. The ultimate decision to proceed with anesthesia must be based on a thorough risk-benefit analysis that prioritizes patient safety above all else, in strict adherence to regulatory requirements and professional ethical obligations. Question 20. The control framework reveals a patient scheduled for elective surgery with a history of poorly controlled Cushing syndrome. The CRNA is reviewing the patient's chart prior to anesthetic induction. Which of the following approaches best reflects a proactive risk assessment strategy for this patient? Option A. Administer a higher dose of induction agent to overcome any potential resistance associated with Cushing syndrome. Option B. Delay the anesthetic until the patient's Cushing syndrome is fully resolved and their hormonal levels are normalized. Option C. Consult with the patient's endocrinologist to discuss the specific hormonal abnormalities, current treatment regimen, and potential anesthetic implications before finalizing the anesthetic plan. Option D. Proceed with a standard general anesthetic technique, as Cushing's syndrome is a known endocrine disorder with established anesthetic considerations. The correct answer is D. Proceed with a standard general anesthetic technique, as Cushing's syndrome is a known endocrine disorder with established anesthetic considerations. Explanation. This scenario presents a professionally challenging situation due to the complex interplay between a patient's pre-existing endocrine disorder, the planned surgical intervention, and the administration of anesthesia. The certified registered nurse anesthetist, CRNA, must conduct a thorough risk assessment, considering how hormonal imbalances can significantly alter a patient's physiological response to anesthetic agents and surgical stress. This requires a deep understanding of endocrinology and its implications for anesthetic management, going beyond routine pre-anesthetic evaluations. The CRNA judgment is critical in anticipating potential complications and developing a tailored anesthetic plan that mitigates these risks. The correct approach represents best professional practice because it prioritizes patient safety through comprehensive risk identification and proactive management. By consulting with the endocrinologist, the CRNA ensures access to the most current and specific information regarding the patient's hormonal status, treatment regimen, and potential anesthetic implications. This collaborative approach aligns with the ethical principle of beneficence and the legal requirement to provide care within the scope of practice, adhering to established standards of anesthesia care. It demonstrates a commitment to evidence-based practice and patient-centered care, as mandated by Professional Nursing and Anesthesia Practice Acts and guidelines. An incorrect approach that involves proceeding with anesthesia without a detailed understanding of the patient's specific hormonal dysregulation and its implications would represent a significant regulatory and ethical failure. This could violate the standard of care, potentially leading to adverse patient outcomes. Failing to consult with the endocrinologist demonstrates a lack of due diligence and a disregard for the unique risks posed by the patient's condition, which could be construed as professional negligence. Another incorrect approach, such as solely relying on generic anesthetic protocols for endocrine disorders without considering the individual patient's specific hormonal profile and treatment, would also be ethically and regulatorily deficient. This overlooks the individualized nature of anesthesia care and the critical need to adapt management strategies to specific patient pathophysiology, potentially violating guidelines for safe anesthetic practice. The professional decision-making process for similar situations should involve a systematic approach. 1. Thoroughly review the patient's medical history, paying close attention to any endocrine disorders and their management. 2. Identify potential anesthetic implications of the specific hormonal imbalance, e.g., effects on cardiovascular stability, glucose regulation, fluid balance, drug metabolism. 3. Consult with relevant specialists, e.g., endocrinologists, to gain a comprehensive understanding of the patient's current status and any specific recommendations. 4. Develop an individualized anesthetic plan that addresses identified risks, including appropriate monitoring, pharmacological choices, and contingency plans for potential complications. 5. Communicate the anesthetic plan and any concerns to the surgical team,